Thank you, Courtney, for the kind introduction. And I also like to extend my thanks to the Canadian Society of Abdominal Radiology for this invitation to present on this topic today. And hello and welcome, everyone. And I guess good afternoon or good evening, depending on where you are and which part of Canada today. And as Courtney said, I'm going to be talking on liver-specific imaging, more in relation to liver-specific MR contrast media. And for some reason, my slides don't seem to be moving. Okay.
Oh, hang on. Oh, that's weird.
Yeah, it is weird. Okay, there we go. There was some kind of a lag there.
Okay.
Anyway, here are my disclosures. I have a speaker agreement with Bayer for this particular presentation, and the opinions I'm going to be expressed are based on my expertise as well as solidly grounded in evidence from the literature. So the overview of my topic overview is to look at the classification and mechanism of liver contrast media. We'll talk about clinical utilization and what impact it has had on outcomes in patient care. And then we'll talk about MR technique optimization as well as workflow optimization, as this is quite critical for liver-specific imaging contrast agents. Now, in terms of contrast-enhanced MR, we have basically two groups of agents, the extracellular agents and liver-specific or hepatobiliary agents. And I'm sure all of you know the differences between these two groups. But just to reiterate, with the extracellular group of contrast agents, the molecules are appearing into the vascular system of the liver by both the hepatic arteries and the portal veins, and they stay within the extracellular space. That is, they stay within the sinusoids and then are taken up by the hepatic venules and excreted via the hepatic veins and into the kidneys. So this is the mechanism for extracellular contrast agents. With the hepatobiliary contrast agents, as we know, there is a dual mechanism. So in an initial part, you have an extracellular component of action, which is going on with these GAD molecules. And subsequently, a portion or percentage of those molecules are taken up by the hepatocytes and excreted into the bile ducts. And that's why these are known as liver-specific contrast agents or hepatobiliary contrast agents. What are these hepatobiliary contrast agents offer in addition to the extracellular contrast agents? Well, we can look at this from both detection and characterization perspectives. For the detection perspective, because there is an increased liver parenchymal enhancement, there is increased contrast to noise ratio between a lesion and a liver parenchyma, and that enhances detection of liver lesions such as metastases. From a characterization standpoint, based on the uptake of contrast within or lack thereof, it can be utilized to characterize certain groups of lesions, particularly hepatocellular lesions, and we'll talk about that in detail as we go on further into this topic. Now, in terms of hepatobiliary contrast agents, there are two agents. Essentially, there is multi-HANS or gadolinium bopta, and then there is Primovis Eovis, or the pharmaceutical name, which is gadolinium EOB DTPA, also known as gadoxetic acid. These agents differ in terms of their dose and relaxivity. So multi-HANS has a dose of 0.1 millimole per kilogram, which is your typical extracellular contrast agent dose. Whereas with gadolinium EOB DTPA, it's a quarter of that. So that's like a 0.025 millimoles per kilogram. Multi-HANS also has a higher relaxivity, and Primovis or Eovis has a lower relaxivity. However, the biliary excretion of multi-HANS is only 4%, while that of Eovis and Primovis is 50%, which means that if you want to acquire an hepatobiliary phase with multi-HANS, you have to give it a long time, and you need to wait for at least an hour or two to get a good hepatic parenchymal enhancement. Whereas with Eovis and Primovis, you could get that as soon as 10 minutes, and typically we would wait for 15 to 20 minutes to obtain an optimal hepatobiliary phase. So now onwards, I'm going to talk about gadolinium EOB DTPA or Primovis or Eovis, which was actually the first liver-specific contrast agent approved by the FDA and subsequently by Health Canada in North America for focal liver lesion detection and characterization. So this particular contrast agent essentially has an epoxybenzyl ring, or known as EOB, inserted between the GAD and the DTPA component of the molecule, which results in its hepatobiliary properties. And the main crux of imaging is based on this particular subcomponent of the molecule. Now, as I said before, with hepatobiliary contrast agents, you have an extracellular phase. So you can have the vascular phase where the contrast is predominantly within the vascular phase. And this typically with EOB-DTPA is up to a minute and a half to 2 minutes. So up to 90 seconds, we can obtain dynamic imaging similar to extracellular contrast agents at no extra cost. And then subsequently, when you move on to after 10 minutes, you get a predominant hepatobiliary phase where you have strong hepatic parenchymal enhancement and biliary excretion, wherein you can assess the hepatobiliary properties of this particular contrast agent. In between 3 and 5 minutes is a so-called transitional phase where you can have mixed appearances of both extracellular as well as hepatobiliary phase appearances. Now, with this contrast agent, about approximately 50% of the contrast is excreted into the bile ducts in a normal situation, and the other 50% is excreted into the urine via the extracellular mechanism of action, similar to extracellular contrast agents. And there are two particular receptors which are relevant for this. On the hepatocyte surface, there is something known as OATP1, which is responsible for uptake into the hepatocyte. And then you have an MRP receptor, which is responsible for pushing out the contrast into the biliary system. And this will be relevant when we talk about hepatocellular lesions. In terms of clinical applications, we can talk about lesion detection, which is based on finding metastases and particularly important for preoperative planning or liver resection. And then we can talk about lesion characterization, which is essentially the differentiation of FNH versus adenoma. And then I'll touch upon HCC. I don't think I'll have time to get into biliary applications, but we'll stick to liver lesions for today's lecture. In terms of metastases, the primary function, as I said, is to detect and plan liver resection, and this is very relevant in colorectal cancer, neuroendocrine cancer, and then also now in pancreatic ductal carcinoma from the point of view of a binary decision whether the patients can go for surgery or not. Additional advantages or utilization of this contrast agent in the setting of known malignancy is to distinguish vascular shunts or benign hyper-enhancing lesions from liver metastases, particularly neuroendocrine tumor, melanoma, and RCC. And then, of course, characterize incidental lesions in cancer, such as focal nodular hyperplasia versus metastases, for example, patient with breast cancer. So let's get into metastatic colorectal cancer. If we talked about the resection of liver metastases before 2000, it was essentially based on a lot of factors which precluded most of the patients, such as age, number of metastases, size of the lesions, tumor-free surgical margin, bilobar metastases, hyaline-lymphadenopathy, and extrahepatic metastatic disease. But since the landmark publications in 2006 and 7, which showed that the more you resect in terms of liver metastases, the better patients' disease-free survival or 5-year survival, this has become a standard treatment for colorectal liver metastases and is not considered a palliative procedure. So today, very aggressive criteria are set. So essentially, you can leave behind 2 adjacent liver segments, maintaining vascular inflow and biliary drainage with a sufficient future liver remnant of approximately 20 or 30%, depending on background liver disease, for a patient to undergo these kind of resections. And also patients who are not upfront resectable may be considered for downstaging with chemoradiation or even with procedures, liver-directed therapies such as RF ablation. So there is a lot of data showing the utility of gadolinium EOB-DTPA in the setting for resection for colorectal metastases. And this is just a meta-analysis now, which is getting long in the tooth. About 12 years ago, there were 13 studies showing that in approximately 19,000 colorectal liver metastases, this contrast had a sensitivity and specificity of greater than 93% with an area under curve of 0.98, and no other modality has matched this. This is in reference to CT scan on that particular group of studies. What about PET? We know that a PET is not good for detecting liver metastases. And so here's an example where you have 2 liver metastases on hepatobiliary phase, which are not visible even in retrospect in PET. And so PET suffers from a lower sensitivity of 70% and is not enough to guide liver-directed surgery. We know this very well, but it's good for extrahepatic metastatic disease. What about the comparison with extracellular contrast medium? How well does EOVIST MR do against ECCM? And in this particular study published by Zek et al., they showed that when you include Promovist in the pipeline for imaging of these patients, it reduces the need for a second imaging test. And when Promovus MR was used as a second imaging test, there was a change in surgical plan in approximately 20% of patients within this study. In terms of the surgical planning, apart from the number of metastases, the location of the metastases also has an impact. So here we have a CT showing you a metastatic lesion in segment 7. However, on the Promovus MR, we can find additional metastatic deposits sitting between the middle hepatic vein and IVC in segment 7, also seen very well on the diffusion-weighted imaging. And this is a critical location because it requires either taking the middle hepatic vein in the surgical or resection specimen with the right hepatectomy, or requires reimplantation of that middle hepatic vein in the IVC. And so this kind of detection has quite critical consequences on surgical planning. In terms of patient outcomes, this study recently showed that when you include Promovus MR in the group of patients in addition to CT, obviously because you detect more lesions and you probably are resecting more liver metastases in these patients, there is higher 5-year survival as opposed to in the group of patients where you utilize CT only. So there is a direct correlation again here in terms of the outcome or survival outcomes for patients when you include Promovus MR in the evaluation of colorectal liver metastases. How about after chemotherapy? So as I said upfront, if surgery is not possible from a liver resection perspective because of the number of metastases, often these patients will undergo downstaging with neoadjuvant therapy. And particularly after neoadjuvant chemotherapy, there's a lot of hepatic steatosis which can set in, and this can mask liver metastases quite easily. So in this particular set of images, there are liver metastases which are just not visible, and you can pick this up quite easily on the Promovus MR images. And several studies have showed the implications of this after chemotherapy as well as listed below. In fact, the potential surgical plan is even greater in patients who have been downstage with chemotherapy, particularly because of detection of increased number of metastases which are just not visible on CT because of hepatic steatosis. Let's move on to neuroendocrine tumors. So in neuroendocrine tumors, it's a broad group of malignancies, as we know. Liver metastases overall are a poor prognostic marker, essentially, especially when they're not amenable to surgical resection or ablation. And the early detection and accurate delineation is quite critical to determine what is the most appropriate treatment, whether it's going to be surgery, is it going to be some form of ablation, or do the patients need arterial chemoembolization. Currently, there is no consensus regarding the best imaging approach for detecting liver metastases from neuroendocrine tumors, and in various guidelines include both CT-MR as well as functional imaging, as you know, which is gallium-68 dotatate PET scan as valid investigations in these group of tumors. However, there is literature again showing that when you utilize gadolinium EOB DTP and diffusion, there is high accuracy for the detection and characterization of liver metastases from neuroendocrine tumor, as in this paper from 2020. And more recently, a paper from my hospital group compared gallium-68 dotatate PET scan, PET CT against Promovus or EOB DTPA for the detection of liver metastases in the setting of well-differentiated neuroendocrine tumors, and EOBIS or Promovus was superior to dotatate PET CT as well. So here's an example of a patient with neuroendocrine tumor where you can see on the CT there are multiple small hyper-enhancing areas. There are some bigger lesions which look like mets, but it's really hard to tell what is the exact disease burden in this particular patient. On the arterial phase of the MR, again, you get a similar picture of the CT. You get these tiny areas and some metastases probably, but again, not definitively assessed for the disease burden. And when you go into the hepatobiliary phase, you can pick out all these tiny metastases, which are just not visible or not definitively characterizable because of the differentiation between shunts and small metastases can be quite difficult in the absence of washout. So this hepatobiliary phase picks up all these small metastases definitively, and that changes the management dramatically in this patient because this would no longer be considered upfront resectable. In the setting of pancreatic adenocarcinoma, as I mentioned, this is not really a indication to actually do liver resection, but is to actually preclude pancreatic surgery. So liver metastases in pancreatic cancer essentially excludes pancreatic ductal cancer resection. And as we know, CT is the recommended modality for staging of pancreatic ductal adenocarcinoma. But approximately 20% of patients, up to 20% of patients, can have unexpected liver metastases despite an adequate high-quality preoperative CT, and this results in a futile open-close aborted surgery. So we looked at this, whether utilizing preoperative liver MR in addition to the staging CT, can this help reduce open-close laparotomies? And we found that in this population, when we inserted gadoxetic acid MR or Primavist MR, we had a 14% reduction of these futile open-close laparotomies, and hence now all our patients undergoing potentially pancreatic ductal cancer resection get a Primavist liver MR before to exclude liver metastases and prevent these futile open-close laparotomies. So here's an example from that particular study that I showed you. No liver metastases was seen on the CT, and we can pick up a small rim-enhancing lesion in segment 6 with restricted diffusion and hypointensity hepatobiliary phase, confirming a liver metastases. Let's move on to hepatocellular lesions, and the big three lesions that we're going to talk about are FNH, hepatocellular adenoma, and hepatocellular carcinoma. And so FNH versus adenoma distinction, as we know from older literature based on liver-specific contrast agent, is essentially stating that an FNH is hyperintense or isointense to the background liver parenchyma as it contains bile ducts, and the contrast gets excreted within the lesion. And an adenoma does not contain bile ducts and therefore is hypointense on the hepatobiliary phase. This explanation is kind of accurate, but is not really the real reason why this particular phenomenon happens. And the real reason is at a molecular level. So if we look at this hepatocyte with those receptors that I mentioned at the introduction of my lecture, in a lesion such as FNH, there is an overexpression of these OATP receptors, and therefore there is increased amount of contrast which is getting into the hepatocyte and then is getting excreted into those unconnected bile channels. Whereas in a hepatocellular adenoma, there is actually downregulation of those OATP receptors, so actually very little contrast is getting into the hepatocytes, and therefore there is no question about a strong degree of excretion into the lesion and therefore hypointense on that hepatobiliary phase. So here's a classic FNH at the top and a typical adenoma at the bottom. So you have a large hyperenhancing mass on the arterial phase, no washout on the portal venous or delayed phases, and then you have quite homogeneous hyperintensity on the hepatobiliary phase with a central scar. On the other hand, at the bottom, you have heterogeneous hypervascular hyperenhancement of the arterial phase, no washout. You can see some rim there. And then on the hepatobiliary phase, the lesion is essentially hypointense. So these are the two extreme scenarios where you can get hepatocellular lesions having contrasting appearances. However, do all hepatic adenomas look hypointense on hepatobiliary phase? And the answer is no, because the hepatic adenomas, as we know, there are three distinct subtypes, at least from an imaging perspective. So although there are 5 subtypes, the 3 main subtypes that we can try and differentiate with MR are essentially the fat-containing or the HNF alpha subtype, the inflammatory subtype, and the beta-catenin subtype. And it is well known that it's actually only those fat-containing subtypes are actually hypointense on the hepatobiliary phase, whereas the inflammatory and the beta-catenin subtypes can actually have a mixed degree of hyperintensity and hypointensity on the hepatobiliary phase. So that's something to be aware of and keep in mind when trying to distinguish these lesions. So is this because this is a problem with this contrast agent? And the answer is no, it's a problem actually with the spectrum of the lesions. So while we distinguish FNH and adenomas as 2 distinct entities at a molecular level, these lesions are on a spectrum. On one end, you have FNH with those arterioles and bile ducts within the central scar. And on the other hand, you have the hepatocellular adenoma with none of those bile ductules, but only these arterioles. And then you have these mixed states in between where you have an inflammatory adenoma sitting right in the center. And then on either end, you can have either mixed type of lesions. And this can result in somewhat confusing appearances or non-diagnostic appearances for distinguishing the 2 extreme ends of the spectrum with a hepatobiliary phase contrast agent. To just show you an example of that, here is a lesion in segment 2 of the left lobe, which looks quite typical for an FNH with uniform hyperintensity and hepatobiliary phase with a central scar. So I have no problem in diagnosing that as a classic FNH. However, when you look at these two other lesions in another patient at the bottom here, we can see that this lesion, although looks like an FNH on the arterial phase with a central scar, has mixed pattern on the hepatobiliary phase, and this large lesion is quite heterogeneous on the arterial phase, and again has a mixed pattern on the hepatobiliary phase. So in this situation, I would not venture out and give a definitive diagnosis of an FNH or adenoma, and in fact, they may be in the mixed FNH adenoma spectrum, either requiring a biopsy resection or interval surveillance. While we're on the topic of hepatobiliary phase retention, I do want to mention you do not want to make this error of not looking at the dynamic images, particularly in patients with colorectal cancer, where you can have the central retention from the extracellular spaces within the metastases. So they have a lot of desmoplastic tissue and leaky vessels, and that can result in accumulation of the extracellular component of the contrast, which may persist on the hepatobiliary phase as subtle hyperintensity. So obviously you're looking at T2 diffusion as well as your dynamic images and not just at the hepatobiliary phase to make the diagnosis, but just be aware of that. Similarly, with hemangiomas, also you can see retention on the hepatobiliary phase, which is actually just the blood pool activity persisting onto the 20-minute examination. So those two pitfalls should be completely avoided. Moving on to HCC, in the setting of HCC, we know that when we utilize the typical signs of HCC, which are arterial phase hyperenhancement and focal venous or delayed venous phase washout with capsule, that has a 98% specificity for the diagnosis of HCC, and hence a biopsy is not required. However, the sensitivity of this combination of signs is less than 50%. So only half of the lesions or half of the HCCs we will be able to diagnose with a 98% or close to 100% specificity when you include these signs. As a result, as you know, if you're using LIRADs, there are certain ancillary features which favor both malignancy as well as benignity, and one of those features is based on a liver-specific contrast agent such as Eovist or Primavist. So if you have hepatobiliary phase hypointensity, it favors malignancy, and you can increase a LIRADS 3 lesion to LIRADS 4, but not to LIRADS 5, and I'll talk about that as to why. And then if you have a hepatobiliary phase isointensity, that favors benignity. However, hepatobiliary phase hyperintensity is not included, and again, I will talk about that as we move on. So here's how you could use a potentially hepatobiliary contrast agent in the setting of an indeterminate or LIRADS type 3 lesion where you have arterial enhancement and no washout. And you can combine diffusion as an ancillary feature as well, in addition to hepatobiliary phase hypointensity to upgrade the lesion to LIRADS 4, but not LIRADS 5. And the reason for that is, does low hepatobiliary phase signal intensity always imply an HCC in setting of a patient at risk for HCC? And the answer is no, because you can have a intrahepatic cholangiocarcinoma, a metastases, and more importantly, even pre-malignant lesions such as high-grade dysplastic nodules, as well as early HCC, which is the histological definitions, can show hypointensity on hepatobiliary phase. So there is a tendency to upstage these lesions into HCCs if you're using that as a sign to move it up to a LIRADS 5 lesion. And as a result, you have to restrict it to suspicious category and not to a definitive category for HCC. Remember, I said we can only use isointensity, but not hyperintensity. And the reason is that HCCs, of course, can take up hepatobiliary contrast agents and look hyperintense on hepatobiliary phase. They're typically heterogeneous, and particularly those HCCs which have the expression of those OATP receptors, which occurs in almost 9 to 20% of HCCs. You can have this heterogeneous uptake on hepatobiliary phase with a typical HCC on histology. So how does Primavist or Eovist MR compare against extracellular contrast agents? And these are three systematic reviews and meta-analysis for the literature that I just want to present here. and summarize. So these were the results from those studies, which included several other studies within those meta-analyses, as you can imagine. And the first one showed slightly increased yield with gadolinium EOB GTP-MR, with the sensitivity increasing about 10% and specificity also increasing close to 10% compared to extracellular contrast agents. However, the second and third major systematic reviews and meta-analysis actually showed no statistically significant difference compared to extracellular contrast agents. And as a result, we don't utilize Promovis or Uvis, at least in our institution, for the routine staging of hepatocellular carcinomas, particularly in patients at risk for HCC or transplant requiring a transplantation. Additionally, you have to keep in mind that patients who are cirrhotic, particularly child C, which is advanced cirrhosis, or the bilirubin is more than 3 milligrams, you may have very poor uptake and excretion, and as a result, there's really no utility of performing a hepatobiliary contrast agent in those particular group of patients. So if you're utilizing this in cirrhotic patients, do make sure that they're not having child C cirrhosis, as it is of no use. And then in the next 5 minutes, probably I'll just touch upon MR technique optimization and workflow. So because this is a different contrast agent as opposed to extracellular contrast agent, there are several nuances that need to be adjusted for in your protocol. The first is the arterial phase. Now, this has a quarter dose of a regular extracellular contrast agent, and this can result in a lower relaxivity. And because of that, you need to adjust your flow rate to increase the signal within the arterial phase. And additional issue with this particular contrast agent has been described is the truncation artifact or Gibbs phenomenon, which was postulated be due to a small bolus of contrast passing at rapid speeds through the aorta, causing ringing artifacts. Subsequently, it was shown that this is actually not truncation, but is actually occurring because of acute transient dyspnea, where the patients really can't hold their breath during the first pass effect of the contrast during the arterial phase. And this has been proven with respiratory bellows as well. So this is a true phenomenon. And again, this is related to the dose and the flow rate of the injection. So when you reduce the the flow rate to 1 mil per second, this can actually be decreased. So the proposed solutions are, one is to modify the injection rate, which is the easiest, is to drop the flow rate to 1 mil per second, or acquire multiple arterial phases, which requires advanced MR hardware and software, which many scanners may or may not have. You can also perform free breathing acquisitions, which are, again, multiple arterial phases, require some advanced software. Or you could perform shorter accelerated acquisitions, such as cryptoremia, twist wipe, which again requires further advanced sequences. So the easiest solution, as I said, is to drop the flow rate, and that's what we do. So we will do a flow-triggered examination where the technologist is injecting the contrast agent, and you're watching the contrast agent pass into the aorta. And as the contrast reaches the descending portion of the aorta, the scan is triggered, and you can get quite a nice arterial phase with this contrast agent, as you can see here. If I showed you this, you won't be able to tell the difference between an extracellular contrast agent and a hepatobiliary contrast agent. On the hepatobiliary phase, you can utilize something known as accelerated techniques on T1, such as cryptoremia, if you have access to those on your scanners, and you can perform high-resolution imaging, particularly for detecting small liver metastases. And if you don't have these accelerated techniques, there are still options to do certain, three-dimensional respiratory-triggered IR-based great echo sequences on older scanners as well. In fact, that's what we used to do before we had cryptoremia on our scanners. Another comment is the flip angle. When we look at T1 weighted images, usually the flip angles are set to be around 10 to 12 degrees, and that can reduce your T1 weighting and contrast to noise ratio. As you increase your flip angle, you actually increase your contrast to noise ratio within the liver parenchyma. In this example, I'm showing you an FNH there in the center of the liver, which is quite well seen on all the flip angles. But if you look at just lateral to that, on the early flip angles at 12 degrees, you can't see anything. But at 20 and 25 degrees, you start to see a subtle hypointense lesion, best seen at 30 degrees in this particular example. So we increase our flip angle to 25 to 30 degrees for the hepatobiliary phase. And this is something that you should adjust on your scanners as well. So in summary, the technique optimization, you want to adjust your flow rate to 1 ml per second, use some kind of bolus triggering or fluoro triggering. We use a saline chaser because the volume of the contrast is quite small because of the quarter dose per kilogram. And then use that higher flip angle for the hepatobiliary phase. And then finally, if you're using in patients who have cirrhosis, make sure that they're not child C cirrhotics or have a bilirubin more than 3 because you'll get a very poor hepatobiliary phase enhancement. And finally, in the last couple of minutes, I'll just touch upon workflow optimization. I think I spoke about this during the abbreviated protocols, but in case many of you did not attend that, I'll just talk about this very briefly here with respect to Promovus. So your routine extracellular contrast agent-based liver protocol includes unenhanced T1s, T2s, diffusions before contrast, and then you inject the contrast and obtain your dynamic images. And typically your grading time or scan time is approximately 15 minutes with a slot time of 20 to 25 minutes, depending on efficiencies. Now, if you utilize a liver-specific contrast agent, because you're obtaining a hepatobiliary phase at approximately 15 to 20 minutes after the contrast injection, this naturally results in an increased time, but you can compensate for some of that time by performing only the unenhanced T1 before the contrast injection and moving the T2 and diffusion weighted images immediately after the dynamic and between the hepatobiliary phase, and thereby gaining approximately 10 minutes back. So still it's longer by about 10 minutes compared to an extracellular contrast agents, but not 20 minutes if you didn't adjust your sequence order. Additionally, you could do an abbreviated liver protocol, and we perform this in patients who are downstage with neoadjuvant chemotherapy and colorectal cancer. And so they have a baseline Promovus MR examination already. And it has been shown quite well that you can get quite high accuracy with just T2 diffusion and hepatobiliary phase images in this particular group of follow-up patients. So in summary, optimize your MRI protocol for hepatobiliary contrast agents. This is the mainstay for pre-surgical mapping of liver metastases, particularly in colorectal cancer. It can help in distinguishing FNH and adenoma. However, there's some caveats, particularly in those mixed lesions. You can have confusing appearances, and it may not be possible to give a definitive diagnosis of typical FNH or adenoma in that situation. Cirrhosis and HCC, you can do it. However, there are some limitations as well as the yield, particularly in child C cirrhotic patients. And then I didn't talk about biliary applications as I don't have the time, but you can utilize this for detecting bile leaks as well as assessing liver donor biliary anatomy before liver donor surgery. Thank you very much.
Thank you very much. We will hold the questions till the end. And Dr. Cleary, may I ask you to share your screen, please, with your presentation?
Yeah, sure. I hopefully optimize my Wi-Fi. Is that working better now?
Yes, you sound great.
Oh, okay. Well, all right. Terrific. Well, thank you very much, everybody. It's truly an honor to be here and to be able to participate. I saw some surgeons on the call, but also radiologists. I can tell you that we will have sorry, I've just got to get it set up here.
Not a problem.
Can tell you there will be no talk of flow rates or molecular diagrams, and but we do want to sort of do want to talk about some of the clinical implications and clinical utilization here. So let's see if that'll work now. Okay, great, perfect. All right, and great. Sorry for the choppy start. So my name again is Sean Cleary. I'm one of the liver and pancreas surgeons at UHN and Toronto General Hospital. Again, it's an honor to join everybody today. Here are my disclosures. Obviously, grateful to Canadian Association of Radiologists for the tremendous invitation, and for Bayers for supporting this activity. My other disclosures I don't think will be relevant to this. And really, I think it probably this is not new to anybody in the audience, but the the practice of liver surgery, and particularly hepatobiliary surgery, is increasingly complicated. And we are, I think, probably one of the most imaging dependent specialties among surgical oncologists. Really, we rely heavily on our radiologists and our radiology. I was taught very early not to read reports, but to go down to the radiology department and review the films with our radiologists and actually be able to go through the films themselves. This is a continually evolving field, and I think Kartik alluded to this a little bit, but I'll expand on it, that patient selection and resection criteria are multifactorial and constantly evolving. So I think this creates a lot of miscommunications, but also the need to communicate directly. And we've been the significant beneficiaries of some of the imaging technology, including the development of liver-specific contrast agents. And as Kartik has shown, these really do, we feel strongly, improve patient outcome. And we'll just go through a few examples of those things. So again, as you can tell by even just Kartik talking about the surgical implications of certain lesions, we have an extremely close relationship with radiology that involves direct personal contact and discussion of cases. We go over the imaging together. We do intraoperative consultations, call the radiologist from the OR, or radiologist will come up to the operating room. And obviously we collaborate with in research. And really, I think that we do collaborative decisions around imaging evaluation of lesions, whether that is selecting imaging modalities and also being very interactive and collaborative in terms of using our radiology resources appropriately. What are the best next steps based on the patient characteristics? And so we honestly spend about an hour to 2 hours a week going through cases together, talking about them. Obviously, for the assessment of patients with hepatobiliary diseases and malignancy, we use a multimodality approach. Obviously, I think contrast CT scan for a long time formed the foundation of this. We're lucky in Toronto to have long experience with contrast ultrasound, and obviously we have people like Kartik that are international experts in MRI. And we view these as complementary modalities, that no one test replaces another, but as you can see, there's different utility for various things, particularly then also when you get into add PET imaging with that as well. And for us as surgeons, there are basically three main factors. First is lesion identification. The second is lesion diagnosis. And then the third is anatomic characterization with relationship to the intrahepatic structures. And that really goes to the assessment of resectability. And Kartik kind of alluded to this, but I put it maybe a little bit more simply. We used to talk a lot about the number of lesions that came out and, 4 or 5 or bilateral metastases. We talked about, the numbers of lesions and the size of lesions, and while that predicts outcome, it doesn't usurp the utility of surgery. So we talk not so much by what comes out in a resection, but what stays in. And I think Kartik alluded to this, that we need kind of 2 contiguous segments with inflow, arterial inflow and portal venous inflow, hepatic venous outflow, and biliary outflow. So the definition of resectability really becomes, has evolved a lot. I know that in the past it was, if you had bilateral liver metastasis, that was automatically unresectable. But now I'd say about 80% of what we resect is bilateral. And my least favorite phrase is innumerable metastases, because really, I think with these, when we go through these with imaging, we need to know exactly where each lesion is, because each lesion is important. Because really, the only goal in surgery is to achieve an R0 resection, which is complete resection, maybe with ablation of all lesions. And this is why we're kind of so dependent upon radiology, because the liver is not a translucent organism or organ. We can occasionally feel superficial lesions, but we're really highly dependent on our preoperative imaging to identify where all of the lesions are, particularly deeper in the liver, and the relationship of those lesions to the intrahepatic biliary and vascular structures. And so this is, you can tell that we just can't sort of, guess where these things are. We have to have a roadmap and we have to have a plan. We can certainly use intraoperative ultrasound. We do that a fair bit. But as you know, that doesn't often involve contrast. So it really doesn't, it may identify lesions, but may not characterize them very well. Certainly, I think surgeons traditionally have had a comfort level with CT scans that's just been around longer, is more accessible, and we like the 3-phase liver scan. And that, I think, we've come to appreciate now with the significant evolution of MRI, the limitations of CT. And this is just a diagram I use for the surgical residents and surgical fellows, just kind of summarizing the surgical utility of various imaging modalities. But really, I think, unfortunately for Kartik, who's got to manage all of these resources, our use of MRI and specifically MRI with liver-specific contrast and EOVist, Primovist, has exponentially increased. And again, Kartik talked about these. And I think the one thing that's allowed us to do this is the improved anatomic detail that we're getting now with contrast MRI, whereas previously I think we didn't get the same anatomic and vascular anatomy that we got. And obviously we have the advantage of being able to image the biliary system. So on to the cases now. So I just wanted to, again, show a few cases where MRI really has shown its utility here. And this is kind of a 41-year-old woman from Northern Ontario. She kind of had a change in bowel habit. A colonoscopy showed a cancer in the sigmoid colon at the rectosigmoid junction, and it was actually deemed to be T4B and treated more as a rectal cancer because she received long course radiation. She got a sort of a single phase CT scan. At the time of staging, it was kind of a CT chest, abdomen, pelvis that went all through in a single phase scan. But then when we got triple phase contrast imaging during her long course radiation, we saw the appearance of numerous lesions in the liver there. And so there you can see sort of the contrast component of it. And then so what we did was we had to further characterize this with MRI, and we really see sort of 4 big lesions. We were lucky that we didn't see any additional small lesions, but you'll see this. But so we were able to identify lesions in segment 7, 8, which is the large lesion there, segment 7, segment 6, and then a particularly difficult lesion here in the middle of the left lobe. And while this might have been traditionally considered unresectable, we actually ended up being able to resect her using a 2-stage liver resection approach, where we clear the left-hand side of the liver in one operation, and then we remove the right-hand side of the liver in the second operation. And so that really allows us to tackle bilateral liver metastases in a much better way. So she started off with her first operation. She had a laparoscopic resection of that lesion in the middle of the liver, segment 4 and 2. She had her rectal resection removed, and then she had a portal vein embolization before discharge. And this kind of just shows you her rectal lesion and then the liver metastasis there, and obviously confirms the cytology and the pathology. And then we moved on to the portal vein embolization. This is kind of what we took out. So this was the right lobe of her liver. It doesn't look very discrete, but this is kind of how we come through the liver with a combination of liver dissection devices and cautery. And you can see here sort of the middle hepatic vein groove just at the bottom of the specimen there, which is really, again, as Kartik described, a very important structure for us, particularly in these 2-stage resections. Looking at this and knowing the relationship between the lesion you can see kind of on the surface there, as well as the middle hepatic vein being extremely important. So this is what her liver looked like at the end of it all. And so this was really, this is surprisingly, looking at enough liver for someone to survive on. And so she was able to leave the hospital about 7 days after this. So these are the kinds of things that we can do, but most importantly, it really requires defined identification and localization of lesions, because if we've left a lesion behind in that remnant liver, then we haven't helped her to any great extent. So, you can see how every sort of lesion matters. Kartik alluded to the idea that many of our colorectal cancer cases are receiving chemotherapy beforehand, and obviously that causes significant changes in the liver parenchyma, either sinusoidal obstruction with oxaliplatin or fatty infiltration from irinotecan. And here's a woman here that you can see has had a fair bit of chemotherapy, 6 cycles of chemotherapy, but she was also probably a little bit larger woman. She initially had a resection and then came back a year later with additional lesions, received 12 cycles of chemotherapy before someone actually thought to send her to a surgeon. And you can see here that we've got sort of 3 main lesions that we were able to identify on CT scan. But then as we went to the Primovist MR, we saw additional lesions here that were not originally accounted for. So we were able to address this with intraoperative ablation while resecting the remaining lesions that were seen on the initial imaging. Again, this is a very sort of similar case. This is a large sort of metastasis, colorectal metastasis in segment 4A invading into segment 8. You can see a little bit of biliary dilatation to this level. So again, one might be tempted just to perform what we call a mesohepatectomy, which removes the middle of the liver here. But then as we got our Primovist MR, we found an additional lesion was confirmed to be a metastasis in the left lobe. This patient still remains resectable, but now we have to remove the whole left-hand side of the liver, plus part of the right, and leave her on the right posterior sector. So you can see that change in operative management with adding Primovist MR to the radiology workup not only shows up in studies, but shows up at an individual patient level. So this is the kind of thing that we were experiencing that really sort of convinced us that this was something that we had to continue to do. Again, another sort of case, again, additional lesions found on MR. You can see here staging again with colorectal cancer. Here's the bottom of segment 5 and 6. And here's a lesion that, again, because of some of the background changes and the timing of the contrast, we're not able to see on CT scan, but was clearly seen on MRI. And again, Kartik alluded to neuroendocrine tumors. And again, this is an area where we can be particularly aggressive with resections. And so we can resect up to 30 to 35 lesions and significantly prolong the survival. I actually think that CT is not very good at finding these lesions. And what we've realized now is that as we see the utilization of Primovist MR, our ability to detect and delineate these lesions is far, far superior, particularly in neuroendocrine tumors where they tend to have multiple small subcentimeric lesions that tend to be missed on CT. We've got a few more cases, but I think out of respect for time and questions, we'll maybe hold there. I'm happy to share other cases, but maybe we want to leave a bit of time for some questions.
Thank you very much to both of you. I'd like to now invite attendees to ask questions using the chat feature or the Q&A. And I'm not sure, the speakers, if you can see in the Q&A, there is one question. If perhaps you wouldn't mind starting with that one, please.
Yeah, so I'll just read it out for those. My question is that what is the optimal timing after starting therapy for colorectal cancer or neuroendocrine tumor therapy to perform Primovist liver MRI to show if the therapy is working and also determine when to operate? So I think if Kartik, you're okay, I'll start with that one because it seems more of a surgical question, but I would say that it depends on the therapy. So for colorectal cancer metastasis, we're generally looking at 4 to 6 cycles, which would be 2 or 3 months of therapy. We don't want to do more than that because you actually increase the chemotherapy toxicity on the liver and increases the risk of surgery. And so that would be 2 or 3. Neuroendocrine can be a little bit different because we tend not to use preoperative therapy. But I would say that those are those kind of collaborative decisions that Kartik and I and all the rest of the radiologists and surgeons at our institution are doing. Kartik, I'll give you the next one. Do you see it?
Yes, I see the next one, and that's a great question because this is an important topic which is up on the horizon from a few years. So there are several hepatic functional indices actually, and there's a whole slew of these particular indices that can be utilized to assess liver function both globally, segmentally, as well as at a lobar level. Apart from just the volume. And I think the data is constantly evolving on that, but it is at a point now where some centers have started to utilize something known as the liver enhancement or liver uptake index, with simple, signal intensity ROIs within the liver to calculate this. So yes, this is certainly doable. It is not as widespread as one can expect, though. However, there's only a few centers, particularly in Europe, who are actually using this.
But I would also add that, the traditional volumetric softwares software was developed mainly on CT technology. Some of the newer software packages are able to do those volumetric calculations that Yigang is talking about on CT or MR. But that's just pure volumetric calculations.
Thank you. There's a couple more. I think you might have already touched on these with MRI and, oh, so they can, yes, thank you. Were there other questions? Oh, I think there's one more that might have popped up. Just checking. No, it was just a thank you. If anyone has any other questions, please feel free to put them in the Q&A or the chat.
So Kartik, I'll ask you a question maybe.
Sure.
You talked about that use of patients with cirrhosis and the difficulty in getting the contrast through the liver. We're seeing a lot of metabolic liver disease and a lot of cirrhosis derived from fatty liver disease, which I think is a slightly different, liver texture and liver configuration than traditional sort of hepatitis B or hepatitis C cirrhosis. In those patients where you suspect or there's fatty liver disease or early, metabolic associated fibrosis or cirrhosis, do you have anything you do in terms of contrast dosing, timing, flip angles or something to improve the sensitivity?
Yeah, so that's again, just to clarify that when I was talking about the lack of the hepatobiliary phase enhancement, that was only in very advanced cirrhosis or where you already have clinically the hepatologist or the transplant surgeon has classified them as child C cirrhotics. It is not that rampant in child A and child B cirrhotics. You can still see some hepatobiliary phase enhancement. So the point I'm trying to make is if you have someone with very advanced cirrhosis, given our limited resources, there may not be any additional yield of utilizing a hepatobiliary contrast agent. And so certainly in the setting of MASLD or fatty liver disease, whether you want to call it MASLD or NASH or whatever, I mean, there's nothing different from a protocol standpoint. I think from a technical standpoint, if the patients have a lot of fatty infiltration or hepatic steatosis, in general, there is a tendency to have lower hepatobiliary phase enhancement, particularly if you're using fat suppressed sequences. So in those group of patients, I would recommend using Dixon type of sequences where you have, the 4 in-out fat and water images. Now this is for the radiologist, Sean, but so whoever's online to kind of compensate for that lower hepatobiliary phase enhancement. And this is again applicable to the severely steatotic patients I'm talking about. So it's the same effect. Severe cirrhosis, there's very little excretion. With severe steatosis, you mask the hepatic parenchymal enhancement because of the background hepatic steatosis, which can be circumvented by using a technique known as Dixon for your post-contrast acquisitions.
Thank you. I think
you're muted, Sean.
Sorry, there's one more question here, and that is the ill-defined characteristic of a liver tumor a predictor of poor visualization on intraoperative ultrasound? So ill-defined on MR, I guess.
Ill-defined margins on MR. I mean, so essentially metastatic disease is not ill-defined. And even like, unless you're talking about an infiltrative HCC, most of these tumors will be quite well demarcated on a hepatobiliary phase MR. So I'm not sure that correlation will transfer very well with intraoperative ultrasound.
But what about
you, Sean? What's your experience in the OR?
Well, some cholangiocarcinomas can be more infiltrative as well, so in mixed tumors. So maybe that's what Boris is thinking. But in my experience, most of the time that's yes. If it's got ill-defined borders, no matter what imaging technique it's on, you find it on intraoperative ultrasound, and I really rely on my preoperative imaging to define the extent and make sure that I've got wide margins around that.